Hello, my name is Dr. Katherine Godwin. I'm the medical director of the Adult Eating Disorders Program at Laureate here in Tulsa, Oklahoma. We are making some recordings of our various lectures and outreach, both to patient families and to our professional colleagues. And so this lecture is part of that series, the title being Unintended Consequences, Systemic Medical Complications of Eating Disorders. And so in this conversation we're having this morning, we'll be talking about the medical complications that come both with the restrictive and bulimic eating patterns, and also what happens somewhat in treatment, because there are some complications that happen as the body adjusts to starting the treatment setting. Because this talk is aimed at a mixed audience of both carers and sufferers and providers, I do try to present information at a really accessible level. But sometimes if something feels like it's just a little bit past what you were looking for, just take what you want to from the conversation and don't feel any pressure to follow up on that other part. But then if you're a provider and you've wondered how to talk to your patients and carers about these considerations, I hope this gives you some aid there as well. All right, let's get going. Okay, so I start by talking about a few key principles, because there are certain ways that the body responds to malnutrition that happen across organ system. And so by talking about it in terms of that widespread, then we don't have to repeat it over and over again as we go through each system. And then we will do more of a system by system review. I realized I didn't include my slide that is about the word malnutrition. A lot of patients and caregivers worry about this word malnutrition, and does it apply to them or their loved one? And it's simply a mismatch between the nutrition that you're getting in every day and what your body needs for optimal functioning every day. In somebody without an eating disorder and with an environment that provides well for them, they should be able to get their resources out of oral intake, and the body takes from those resources just like building blocks, breaks them down, and then has that building block of, I'm just going to say Legos, available to build things back up into what the body needs it to be. So whenever you don't have all those building blocks there, that is the state of malnutrition. So it might be that you're not getting certain varieties of food or the volume of certain items of food, so that you just don't have enough in quantity. But in either case, we're talking about malnutrition. Also, if you are eating what might be sufficient for some, but you're doing extreme exercise or you're having purging behavior, that creates its own area of malnutrition, because it's your body is being demanded to take extra resources more than what it's being given, or not being able to hold on to resources. So if there's also that distinction between, well, my behaviors are so-and-so, so it doesn't count as malnutrition, or my weight is so-and-so, so it doesn't count as malnutrition. Those ideas can be easily kind of looked into and broken down and saying, okay, but your day-to-day intake of nutrition and your day-to-day behavior with that nutrition do not match up for optimal functioning. So malnutrition. Okay. So in part, that did cover a little bit of this, which is that whenever your body is having to choose between only having some quantity of a building block, but it needs it for 3 or 4 different functions, it either can just do a little bit less at every function, so all of those areas slow down or aren't optimal, or it may prioritize one function and say, we're definitely doing this, but then we're really almost not at all, or sometimes not at all, doing a couple of other functions. And so that is one of the ways that the body has to choose and prioritize. For some people, they will feel like their body has been very resilient despite behaviors across the field. And that might be somebody whose body is parceling it out a little bit better and just turning all the systems down. Another person, for reasons that are not always clear, but may have to do with just genetic vulnerability, like if thyroid disease runs in your family or blood sugar disorders run in your family, that person may, in normal nutrition and normal behavior, not have a medical issue with those, but in the context of malnutrition, they do start to develop abnormal thyroid function or abnormal blood sugar regulation. And so sometimes that's based more off of your body's own individual frailties, which the malnutrition kind of uncovers. Muscle loss is one of the usually unintended consequences of malnutrition, that usually when people are working on reducing their intake or increasing their exercise or even purging behavior in order to reduce weight or reduce body size, they are focusing more on wanting to reduce fat cells. But fat cells are a source of energy for a body that is in starvation or in a negative balance, but muscle cells are as well. And if the body stays in that negative state, the fat cells may be used early on in starvation, but the body will shift rather quickly to using muscle cells because they're an excellent resource. They provide energy, but they also provide amino acids, which is going to replace some of that nutrition. Additionally, your body also takes magnesium and calcium and phosphorus from your bones. And that's because it needs those things to regulate your cardiovascular system and your neurofunctioning. But your body is just seen as a pot of Legos for nutritional resources. So when you're breaking down due to restriction and you're wanting to seek weight loss, somebody might be focused on wanting to seek fat loss, but they're more likely to shift rather quickly toward losing muscle. Those muscles are of the circulatory and gastrointestinal systems, also the arms and the legs. So the whole body can be impacted in various ways. Homeostasis. That is the principle. I love this little schematic. I won't take credit for that. Heather Morrow, I think, put that schematic there of this balancing ball, but that's a really nice way to think of homeostasis. It is the body's ability to adapt to changes while trying to keep everything in the balance. So almost every vital sign or lab study has a normal value, and it's usually a range from here to here is normal. For body temperature, 98.6 is normal, but anywhere from, maybe 97.2 or something to 99 something, that is actually the normal range. So when that 98.6 is optimal, that is where the body's internal chemistry functions best. But there's some utility to sometimes when our body temperature goes higher, that allows our body's proteins to shift in their activity to where maybe it optimizes something else that's going to help our body work against infection. But it's not the normal state. We don't stay there. Your body works really hard to keep that, whether you're gardening in the sun in Florida or whether you're outdoors in the cool, your body is still working really hard to keep that internal temperature steady. And that uses a fair amount of energy resources. Other areas of homeostasis are blood sugar, blood pressure, and gastrointestinal functioning, though we don't have a key measure for that we look at day to day. So when you are removing resources and putting the body in that strained position, what you will find is that the body may fall out of homeostasis sometimes, especially if there's an abrupt change. Your body was going along nicely, and then there was a sudden change in its resources or in the actions of the sufferer. In that situation, the body doesn't have time to adapt, and it may fall outside of its normal vitals or normal labs. And then if that stressor continues to be there, the body kind of says, okay, this is the best way for me to get the functionality I need while under these stressors. And so it compensates. So briefly, it was decompensated under the acute stressor. And then as the stressor continued, the body then compensated. At any point, then that body that is compensating is no longer functioning optimally. And the next time that it has more strain, it may decompensate again. And that may be more quickly or more severely, or just a step down to another level of decompensation that then becomes stabilized for a while. It is not predictable per organ system how one individual will step through levels of decompensation and then that resiliency of compensating again. We do know that some patients use behaviors and compensate well for them, that another patient might have more extreme consequences that are seen earlier on in the illness. But then that patient who isn't seeing consequences early on may have a significant sudden step down at a later time that's not predicted. So that justification of I'm not sick enough, and I'm not sick enough as evidenced by my labs are okay, my vitals are okay, I don't pass out, I can tolerate this much activity, I'm still doing well at school, all those various ways to rationalize and defend that the eating disorder isn't severe enough. That has a lot to do with this balance of compensation and decompensation. when we start introducing recovery actions, which might be introducing more consistent intake again, or stopping exercise or stopping a purging behavior, the body also has to then compensate for this new shift. And we can get into areas where the shift is so strong that the body struggles to make the shift between whatever the behavior was to this healthier, more normalized state, but it's just not what the body's used to. So if we see decompensation going on in early recovery, we may need to react to that by slowing down the changes a little bit. An area where that particularly comes in this setting is as we do lab studies looking at somebody's phosphorus and magnesium and their total protein values. That lets us know how the body is tolerating the shift from a starvation metabolism into a carbohydrate-based metabolism. And if the body is not managing that shift well, we may say, okay, we need to use a little bit more protein and fat in this person's meal plan right now. Rather than the usual balance of carbohydrate, protein, and fat. We just may need to shift toward any future increases are going to be in protein and fat until we see that the body is better managing this refeeding syndrome. That's just one example. And there are other ways that we work through it, but the lab studies help us evaluate that and help the person's body make the transitions through recovery more easily and more safely. Okay, on to system by system review. I do it this way partly because this is how we learned it back in medical school. We learned kind of some general ideas, and then we learned system by system. So to me, this makes a lot of sense, and I hope it translates well at home as well. But then we've got those key principles that go through each system that I'll just remind you of as we go. So the nervous system, we'll start there. The brain and the sensory and motor neurons that run out of the brain to every toe and every finger and then back up, that is the nervous system. The nervous system has a balance of communication, some of which happens through neurochemicals like, epinephrine, norepinephrine, serotonin. I'm so sorry. The primary brain chemicals that we think of in psychiatry. I think I started in my reverse order, which threw me off. But so those are neurochemicals that are very important in how the brain communicates. They are derived from proteins. We'll talk more about that, I think, on the next slide. And then there are electrolytes, which are driven more by fluid balance. And these elements that you get from your nutrition, sodium, calcium, potassium, and then your body also stores those up and then releases them in times of deficit. So these are the two primary ways that the brain communicates to cause electric signals to go down a system and then back up and regulate. Also, fat tissue or adipose-derived cells line the nerve cells, and they're kind of like insulation on an electrical cord in your home. So if the nerve cell has a good wrapping around it, it's a safe cord, you're going to get a good communication. It's going to speed its way down and speed its way back up. In a cell that has lost some of the fat matter or the adipose-derived cell line that helps line those cells, then you might get less well-regulated communication, including misfires, overreads, or lost communications. And so it might be seen kind of like if you just have that one well-wrapped nerve, then the communication just goes end to end. But if you have a nerve that is wrapped with little openings and holes along the way, then the communication goes from here to here and here to here and here to here and here to here. And so that really does slow down the communication and gives more space for the energy of the communication to be lost. Going on with the nervous system, those imbalances then can result in poor cognition, which is kind of thinking, process, problem solving, word finding, poor processing, mood and anxiety disorders, depression, anxiety, OCD, and disruptions of sensation and movement, because your body gives all those signals on the way out to tell you what to do, and all the sensations on the way in telling you what your environment is doing. So those are the sensations and movement that could be disrupted. The longer the length of the neuron, the more likely it is to be impacted because it has a longer way to travel. And so the neurons that run to the toes may be impacted before the neurons that run to the fingers, but then it kind of comes on up toward the core. And that's for things like numbness and tingling, as just one example. Seizure is a serious possible risk. Obviously, I hope obviously it's not that common. And certainly if seizure does occur, it should be taken extremely seriously because it's not that common and it is a sign that the system is decompensating rapidly and cannot adjust to the behaviors that it's experiencing. And any one seizure may then cause another seizure or go into a series of seizures that the brain isn't recovering from. Seizure is possible from electrolyte disturbance, which can be not getting enough magnesium, calcium, phosphorus, but also of rapid fluid changes, because rapid fluid changes may dilute what was previously an adequate number of those electrons or electrolytes, and then you add a lot of fluid, and all of a sudden the volume in which those electrolytes are is much greater, and therefore the level, the concentration is much less, and that can cause a seizure to occur. And then there's also low blood sugar. Low blood sugar that's happening in a very slow way is more tolerated, but if blood sugar happens to shift very rapidly, as can occur in sudden shifts into starvation or sudden shifts with purging, you might then have such a rapid shift in blood sugar that the body would maybe experience a seizure related to that as well. And there's also coma that can happen from low blood sugar states. So I hope also, though I haven't pointed it out yet, this reminds me that I should, that these various things that might impact the nervous system could come from various different kinds of behaviors. The deficiency in the electrolytes, that could happen from poor intake. It could happen from purging behavior, and that purging behavior could be purging by exercise, by vomiting, by laxatives. So different kinds of purging behaviors. And then if somebody's eating more of one kind of food but has ruled out or rarely takes in other sources of food, then that's out of balance. And the body may have a medical consequence because it's not getting those building blocks that it needs specific to that food group that's being missed. And so each of these organ systems, as we go through, you'll be able to see in most of them that this could be due to restriction, this could be due to exercise, this could be due to fluid loading, this could be due to purging, so that you see that the various behaviors are all impacting of each of the nervous systems, because malnutrition is multi-organ system in its function. Okay. So this is the slide then that goes on to talk about those neurochemicals. Serotonin, norepinephrine, which is also called noradrenaline, and dopamine, which used to also be called adrenaline. These are the key neurochemicals that are identified in the vast majority of psychiatrically active medications, especially the antidepressant class. Like SSRIs are selective serotonin reuptake inhibitors, and SNRIs are serotonin norepinephrine reuptake inhibitors. And those alone make up the majority of psychiatric prescriptions currently. The reason why I'm focusing on those in this setting is, one, how common they are, but also that the comorbidities, the psychiatric comorbidities that go along with eating disorders often include depressive disorders and anxiety disorders. And these are our primary options to help treat those things. But serotonin, norepinephrine, dopamine, they should all be produced in the brain at a steady level based off of our genetics and in the context of good nutrition. And so if somebody has not had depression or not had anxiety, but then they start to have malnutrition and develop depression and anxiety, that may be an indicator that the malnutrition is causing a deficit in these neurochemicals and in their actions, and is actually causing the depression or anxiety. If malnutrition can cause depression or anxiety, then it can certainly make a depression or anxiety that existed before the malnutrition, it can make it worse, and it can make it harder to treat, because the medications that we use, the SSRIs, the SNRIs, they act not by giving your body more of serotonin or norepinephrine. They act by telling your body that the serotonin and norepinephrine that are being released need to stay and act longer at their junction, and kind of fool your body into thinking it has more of it than it really does. So if you're not nourishing your body well, you're not going to have these building blocks that the medicines are acting on. So in that situation, somebody who maybe already was doing well on an antidepressant medication, Lexapro or Zoloft, already doing well on it, and then in the context of malnutrition, their anxiety and their depression became less well treated, that could be an indication that the malnutrition is undercutting that medication from being effective. The pathway is laid out a little bit in the next like set in statements below, but this is a really complex topic, and I have a whole nother lecture that's over an hour where I go over some of the areas in which malnutrition impacts the neurochemicals. So this is just a brief look at that. And to be aware, the essential amino acids, those are tyrosine and tryptophan. In this case, you're getting those from food resources. You can't go take a bottle of tyrosine tablets or tryptophan tablets and get the resource in the way that you would get it from nutrition. And that nutrition is found strongly in quality protein sources and animal proteins in a greater abundance than in vegetarian proteins. So in vegetarian proteins, you have to look carefully at how to balance those to make sure that you're getting these in. So those essential amino acids of tyrosine and tryptophan, through a series of chemical mechanisms, transition into either serotonin or norepinephrine or dopamine. And then dopamine and norepinephrine are actually very related. Dopamine is a precursor of norepinephrine. So anywhere in the body where norepinephrine is being regulated, dopamine is being upregulated as well. Those essential amino acids then are from dietary sources. And then there's folic acid. Folic acid is like a little gatekeeper on that pathway of arrows between the essential amino acids and the neurochemicals. Folic acid is a little gatekeeper that says whether or not this path can go forward and how rapidly it can go forward. Folic acid is also vitamin B9. We're also getting that from our nutritional resources primarily. So that's two different areas, either the essential amino acids or the folic acid, that both come from dietary resources and strongly affect brain chemistry to be available. Additionally, hormone states, hormones that are released in the ovaries or in the testicles, so the gonadal hormones, they regulate whether your body makes more or less of serotonin. So if your body is already suppressing the gonadal hormone functions, as may be evidenced in a woman by not having the regular menstrual cycle or not progressing in puberty at the rate that was previously occurring, that would be an indicator that if the body is not doing that hormone status well, then those hormones are not upregulating the production of serotonin. So a relative decrease in serotonin just from that status. And then of interest in just dieting behaviors. So a person who's otherwise physically healthy and doesn't have a history of eating disorder, but who engages in restriction as a dieting behavior, we know that there are statistically significant decreases in the measurable amounts of serotonin in those people outside of ever having an eating disorder. So it's a relatively rapid and consistent effect that when you pull back on nutrition or you put nutrition out of balance with your energy and resource needs, that this is an area where the body feels the impact pretty consistently and early on. All right, we're going to move on from the neurovascular, sorry, I just combined them from the neurologic system to the cardiovascular system. Cardiovascular system is the heart and all of the vessels on the way out and on the way back in. So in some ways, it's very similar to the neurological system in that it has a core and everything that communicates out and communicates back in. In the case of the cardiovascular system, it's a transit system. And so you've got the pump, which is working really hard and consistently to keep a steady rhythm that's very efficient and moves blood throughout the body. It circulates blood from the heart into the lungs to pick up oxygen and then back and drop off carbon dioxide, and then back into the heart again, and then it pumps again, and that moves it through the whole rest of the system. It might go up to the brain or down through the organ systems or the periphery. And then the veins bring it back up to the cardiovascular system by going through the liver for some processing, and then back into the side of the heart that then is going to go on to the lungs. So it's very much a circuit. Very important. We all like our heart. We want it to work well. When it's not doing its job well, it might not be doing it well in various different ways. If the rhythm isn't consistent, then you're not going to get the efficiency of blood flow. And so the whole system will lose its oxygen drop off and its ability to put carbon dioxide back into the system. So the waste exchange. So if the rhythm is going along in a normal sinus rhythm, like we've all seen on every medical show ever, the normal sinus rhythm is the rhythm that is identified with the more efficient heartbeat. Some of the terms we hear often are tachycardia. That means a rhythm that's going faster than is normal, or bradycardia, which is a rhythm that is going more slowly than normal. And those still speak to it being a rhythm that is efficient in its pumping, but just too fast or too slow. And then there are the other arrhythmias where the actual way that the heart beats changes. And so those have a different impact. But all this rhythm regulation, it comes through the heart muscle, primarily through calcium and potassium. Magnesium does play a role as well. So calcium, potassium, magnesium, we talked earlier, come through your dietary resources. Your body also stores some in your bone health, so that if it's not getting it in your nutritional resources, it can free some up from your bones in order to make sure that this very important system is working well. It's a muscular system, so it can also lose mass in the context of ongoing starvation. And if it's doing its job less well, your circulation is not going to be as strong, so your blood pressure may be lower. But it's also a system that requires a ton of energy just to keep it going. And this is one of the major energy drains in your system. I would say your cardiovascular system, your respiratory system, your gastrointestinal system, and your brain demand a huge amount of resource ongoingly. It really can't pause. And when the cardiovascular system does come under strain, it might just slow its rate to stop putting as much energy into the system. So it develops a bradycardia that is an adjustment or a way to compensate for the poor nutritional state. It's also possible if your hydration levels aren't staying up, that blood pressure could fall because you don't have enough total fluid running through this system. Or when your protein levels are irregular, protein is part of what helps be in balance to keep hydration in the cardiovascular system. So even somebody who seems to be hydrating well or overhydrating may actually be dehydrated or low volume in their cardiovascular system if they are protein malnourished. And all of those things can cause the blood pressure to be lower, and the body will have to work extra hard to regulate that. What we will often see in that dysregulated system, or in a system that is regulated and compensated in the resting state, but is too strained by even simple movement, is a change in what we call orthostatic vital signs. And in those, we're taking a pulse and blood pressure when you are at rest, and just evaluating wherever those are. They may be within normal, they may be a little bit slow or a little bit low, but the person is medically feeling well. And then the person goes from rest to standing, and just that simple action. Obviously, a very fit person should be able to go from rest to standing and tolerate that extremely well. The accepted normal is to have up to 20 beats per minute of increased pulse to try to support blood pressure for this action change. But in somebody who is very fit, we would expect their heart rate to have to change much less, because that action is easily compensated for. And somebody who is malnourished or is out of balance in doing their fitness activities where they're not nourishing those activities, it might suddenly, though, present a different picture where somebody goes from rest to standing and their heart has to go so much faster, sometimes 30 or 40 beats per minute faster than its resting rate. And then for other people, sometimes we'll see doubling of the resting rate or more. And that gives us an indication that that body is probably experiencing some level of dehydration, but also that the resting rate is very slow or bradycardic due to malnutrition, and your body's compensating. Because when you stand up, your body says, okay, but now I can't keep your blood pressure there, so I have to beat really fast to try to get the blood pressure there. If your body beats really fast and it keeps your blood pressure level, or it even goes up a little bit, that's going to be protective of feeling lightheaded or dizzy. But if you stand up and no matter how much your heart is racing, your blood pressure falls, that's going to be more likely to be associated with that feeling of being dizzy, lightheaded, tingly, feeling your vision go dark. And that further signifies a decompensation. Your body cannot compensate for that action. And that lets us know that low resting blood pressure and low resting pulse are not about fitness, but are about malnutrition in a decompensating system. So many of our patients experience the dizziness on standing, the change in vision on standing, but have built a pattern of just walking through it, which of course increases fall risk and the likelihood of then not being able to compensate for that blood pressure as you're in the middle of a room or on a staircase or something, which is just much more dangerous. if somebody is experiencing that, just pausing and standing, or if pausing and standing isn't going to work, just sitting back down, that is an appropriate medically healthy response. But it would draw attention from loved ones or caregivers who might say, oh, have you had anything to eat today? Or can I get you a glass of water? Which is concern that may not be wanted by the person. So that action of I'll just stand up, and even if my vision goes dark or I feel dizzy or lightheaded, I'm just going to keep on going. It is very typical. Okay. The way that the vessels act, one is the arteries on the way out of the heart are very muscular, and so they can help control blood pressure by constricting down and making blood pressure higher, or opening up to make blood pressure lower, which also allows for cooling in the system. And the primary job of vessels that go above the heart is to perfuse the brain. And that is part of the reason why dizziness occurs so much in the brain, is if you're having low blood pressure, you're going to continue to perfuse the lower part of your body well, while the upper part of your body that has to fight gravity and is above the level of the heart is going to be the first system to feel that dizziness. Your body's basically saying, hey, I can't keep up with your blood pressure because I'm pushing against gravity. So you either need to sit down, or I can lay you down by causing the body to pass out. And then the body doesn't have to work against gravity to get the blood pressure flowing. And that's going to save the person who otherwise was going to be having the brain be deprived of energy. So that is one way that our bodies try to give us messaging. It's also a really good time to look at, are you hydrating? Does your hydration have electrolytes in it? So some sugars, but also maybe some salts, so that your body can really take in that fluid in a way that's going to be meaningful in the cardiovascular system and also give it some energy. All right, I feel like we've already talked about this a little bit, just that the vessel walls are muscular. So just like the heart muscle, they're subject to muscle wasting. So that's one of those key points that comes through. And then that in malnutrition, we often see the lightheadedness on standing. All right, deep breath. Next system. So the gastric system, that's everything from, well, entry to exit, everything from oral to rectum. And I always tease when we do this in person, the talk is usually either right before lunch or right after lunch, but there's never a good time for so many people. But if you've ever been a patient here or been involved with us for very long, I think we all get to be very fluid in talking about the GI system and not even twitching. So the gastric system is, we're going to go through it bit by bit because each of the different parts can be impacted in different ways. And when you're working on nourishing the body again and not using compensatory behaviors like purging or restriction exercise, when you're not doing those things, the body's ability to tolerate nutrition is different. And we have to look at how each of the systems is impacted for each person to know how to best help their body be able to tolerate the refeeding in a way that doesn't make food unpleasant to the best degree possible. All right, so starting in the oral, when I was going through school, we studied dental health in 4th grade, and I remember really strongly that big mouth with the big red toothbrush. And in my 4th grade class, we all chewed that little red tablet to make the plaque on our teeth show up, so then we would brush even better. I think that a lot of parents might be right in my age category, or a lot of loved ones, and certainly some patients are there. So that is to help you remember what you learned way back then. But we learn new stuff all the time. And so we'll start with enamel. Enamel is the protective cover of the tooth. It's like the top coat over nail polish or varnish over a stain. So it's the protective cover over the tooth. And it extends over the whole tooth that you can see, and then just a few millimeters below the gum line. It helps sugars and things not stay on the teeth so that you can brush those surfaces clean more easily. When somebody has an eroding gum line because of malnutrition or overbrushing or poor dental hygiene, whatever reason they have an eroding gum line, then the part of the tooth that is not covered with enamel becomes visible. A lot of people will think of dental issues and eating disorders, and they'll think about how purging behaviors can cause enamel erosion, which increases sensitivity and then increases the risk of cavities. But malnutrition causes gum recession, which increases exposure of the enamel, which increases risk of cavities. So again, this is another system that you can clearly see are impacted by eating disorder behaviors, regardless of which category of behavior. There's definitely risk. And so, yes, the acids from reflux and from purging can cause erosion of the enamel. I'll mention reflux and purging because in purging behavior, we often see that the front of the teeth, or more so the back layer of the front teeth, is where we get early signs, and then it can be very widespread after that. But in reflux, it's actually the back teeth, because reflux is coming up the esophagus to the back of the mouth or throat. And in reflux disease, the acid is coming up and getting the back teeth, and you're going to see more erosion back here. The dentist in the family can easily look in the mouth and be able to tell whether there's dental erosion of the enamel and where that's happening. But if you tell the dentist that there is an eating disorder going on, then they can feel free to give you more open feedback. Whereas if they don't know that the eating disorder is an acknowledged problem, they, one, may not look at it and consider it in the same light, but two, they may not know what they're getting into if they mention something, and might then want to avoid saying too much because they don't know about the readiness to receive that information. So when you see the family dentist, definitely let them know if there is eating disorder so they can give specific feedback and then specific recommendations. I do want to say that overbrushing or overflossing cause damage as well. And overbrushing or overflossing can be present for somebody who has eating disorder for a few different reasons. One might be that they're trying to cover up the breath and the idea that they've just had purging behavior, or maybe brushing their teeth is a reason to be in the bathroom after meals. And it could be that food is not a flavor they want to continue to have because they've developed a distaste for some food items in their eating disorder, and so that's a reason. Or if they have OCD, and that OCD includes dental hygiene as part of their anxious compulsive behavior, that overbrushing or overflossing. And the dentist can also be helpful there in telling you whether that dental erosion that they're seeing seems related to overbrushing or overflossing. And then I want to mention, I said we learn over our lifetimes. My own dentist told me during pregnancies that an area where dental erosion happens that people don't think about is when there is vomiting occurring, that acid softens the enamel of the teeth. And so for the 30 minutes or so after having a vomiting episode, if you brush your teeth right then, the enamel is softer and it will break down that enamel faster. So they were bringing it up in the context of pregnancy, that if you do have vomiting as part of the pregnancy, to not brush or floss right away, but just rinse your mouth with cool water and then brush or floss a little while later. But that also applies to this, that if somebody's having purging behavior or severe reflux, to not brush or floss right after that's occurred, because the tooth is going to have wear and tear faster. Okay, so once your mouth has chewed and swallowed, now we're into the esophagus. The esophagus is a muscular tube that runs from your throat to the very top of your stomach. The action is very straightforward. It's just a muscle squeeze from the top to the bottom, kind of like not a constricting snake. I got into this discussion once before. I apparently don't know my snake class well. But this action is called peristalsis, and it's just a series of little muscle contractions down the length of the esophagus, entirely meant to keep food down, and also that whatever you swallow makes its way down. The esophagus is not innervated in a way that you can feel every bit of it the same way. The bottom third of the esophagus, you don't normally feel acid there. So if somebody's having reflux into the esophagus, but in the bottom third, they tend to experience it more as pressure. But then some people, their reflux can go on in an acidic way to cause heartburn, which is the pressure, but also of a burning sensation. That usually occurs in the upper 2/3 of the esophagus. That has to do with the lining of the esophagus. The lining in the lower third is more similar to the lining of the stomach, and then the lining of the upper 2/3 is more similar to the lining of the inside of the mouth. So the upper part lining is not meant to have strong ongoing acid exposure. So when that part of the esophagus is getting either acid exposure through purging or through reflux on an ongoing basis, the tissue inside of the esophagus can start to have changes from that ongoing assault of acids. And that's where we can see inflammation and sometimes swelling, redness. Sometimes there can be areas of bleeding or easy friability. But there's also a precancerous change that can occur with ongoing reflux or ongoing purging. And this is an area that people would not be able to feel what was occurring very well. They might just feel like they have heartburn or reflux, and now it's a little bit worse than it used to be. So maybe they take some more Tums. But that would be saying that you need to have a scope to look at, which is where under sedation, a GI specialist or a gastrointestinal specialist will put a scope down and look at the lining of the walls of the esophagus and of the stomach and be able to give feedback of the state of damage that is occurring in that person's system. Just like all the other systems, somebody might have very little signs of inflammation despite a lot of behavior, and somebody else might have significant inflammation and evidence of damage and precancerous change, even if they haven't had as much behavior, or they're more experiencing reflux rather than the purging behavior, which is more volitional. So it is important if somebody's having a lot of reflux on an ongoing basis or has had purging behavior to have a scope so we can evaluate a baseline. And then, of course, if there's disease state, then treat it. But then even if there's a baseline, then we know if we do need to look again in a year or 2 years or 5 years, we have a baseline to look back and say, so how much change has occurred? Sometimes with that reflux that's going on, especially there's also purging, which is a more violent action within the esophagus. There can be tears that happen within the esophagus. And then the skin tissue, as it heals from that, can heal just like skin tissue on your hand. But sometimes it might have a scar. Again, just like tissue on your hand. Sometimes there's a cut and it just disappears and goes away as it heals. And other times it kind of builds up a bit of a scar, and that scar tissue doesn't move in the same way as the skin that was there before the scar. When that occurs in the esophagus, you can get areas where the skin of the esophagus isn't moving in its normal way. And sometimes people will get a buildup of scar tissue and damage in both just the lining and also more into the muscular wall. And in those patients, they might start to get a feeling of food getting stuck on the way down. And usually they can say, it's right here or it's right here. They can just feel it. It's very consistent every time. And that needs to also be evaluated because that might show us that there's a constricting or a narrowing down of the opening of the esophagus where food is more likely to get stuck. And that requires a mechanical treatment at the time of the scope to kind of dilate and pull that back open. But if ongoing reflux or ongoing purging is happening, it will close in again for most people who suffer that. So we do also want to hear really carefully if somebody tells us they feel like food is getting stuck when they swallow. That's another reason to go ahead and get imaging done. All right. The junction between the esophagus and the stomach is called the lower esophageal sphincter. I love it when things are named more for their position in anatomy or what their job is rather than the name of whoever found it, because lower esophageal sphincter makes sense to me. Sphincter is just a tight, round muscle group. So that sphincter's job is just to stay nice and closed whenever you're not eating, to keep stomach acid in the stomach and not have it coming up. And it opens up to allow food as you swallow to come down and pass it, and then it closes again. If people have hernias, which can describe various things, but hiatal hernias, congenital hernias, they can be things that somebody was born with that kind of runs in the family, or it could be a hernia that developed over time. Sometimes you're going to get a pressure differential in the system that's going to cause the lower esophageal sphincter to not be able to do its job well and get a lot more reflux then. And then if somebody has congenital throughout their lifetime, since development, they've not had a good tight esophageal sphincter, then they're going to be somebody who experiences a lot more reflux much more easily. So outside of the eating disorder, that creates an issue of increased risk in the esophagus, and also issues with feelings around fullness and heartburn and reflux. But then if with the eating disorder on top of it, it creates issues both if there's a purging behavior, but then also if we're doing refeeding, because in refeeding behavior, we're often eating past the point that system has been used to, and so they experience more fullness and very delayed, prolonged fullness. And during that period of fullness, that sphincter isn't holding food down in the stomach as well, so they're likely to experience a lot more reflux. And those are things we want to treat, not just say, it'll go away, it'll get better over time. But we really want to treat it. We want to bring down the acid levels so that the acid that is reaching the walls of the esophagus isn't going to be as damaging, but it's also then not going to be as painful. And by reducing the acid, we're also decreasing inflammation, which is going to help the system heal better. But of course, the most important thing is to stop the behavior. But it's easier to stop the behavior if the system isn't hurting you. And you don't want to build the association of when I eat food, I feel ill, because we're trying to work on normalizing food and making food healthy and safe and smart. And to have it where food is painful and food causes symptoms that go on for a long period of time really increases that feeling of needing to avoid it. So the stomach lining is totally fine with the acid by and large. We can see changes in there. The job of the stomach is to break down food even further, so basically chews it up. And then once everything is the consistency more of a smoothie, it opens up a valve at the end, which allows food to flow out of the stomach. It is important to think about that function like a blender, because just like a blender, you need to add whatever the solid material is, whatever the food is that you're blending, but then you add fluid to it, because if you don't add fluid, it'll take forever to blend up. But if you add fluid, it'll blend up really well and move through. Same thing when you're working on eating your meal plan. If you take sips of fluid throughout the course of your meal, it's all going to blend up much better. But if you're not getting enough fluid or just loading the fluid at the end or the beginning, you're not going to get as consistent of digestion. You're going to feel full a lot longer. And so whereas some people avoid the fluid saying, I already feel full, the fluid will actually help the fullness move along. When you are not regularly feeding your GI system, it stops putting as much energy into the system, which is a way to conserve energy. But then we have to train the system to pick back up. And part of that training is feeding it several times a day. The way the system works together is really fantastic, including there's a gastrocolic reflex. So you eat a little bit and then your colon says, make way below. And it helps your whole system just kind of function and keep things moving through it like a highway system. So any part that disrupts that system is going to cause a disruption through the other parts as well. So in the case of the stomach, if it's got dysmotility, it's not blending things down well, more upset stomach, more indigestion, early and prolonged fullness, but also gassiness and distension, which is where the gas feels like it's kind of bloating, and it can do that in the stomach, but it can do it in the small intestines and the large intestines, and then issues with constipation or irregularity. Continuing to move through the system. If somebody is abusing laxatives, the body learns, okay, we don't move the GI system unless we're getting a laxative. So whenever the laxative's not there, everything stops or slows down significantly. And when the laxative is there, the body has a response. But then the person usually has to keep increasing the amount of laxative they're using to still get the same response, because the body keeps compensating for that trigger to help it know when it's time for it to move. So the way that we rehabilitate a system throughout that is small meals and snacks throughout the day, and then also cessation of any laxative that is a stimulant laxative, because those are dangerous to the bowel. They cause potential for strangulation or loss of circulation to areas of the bowel wall. But then we use what we call osmotic laxatives, which is laxatives that stay within the gut and pull fluid to them, and that keeps the stool much softer so that it can then progress more gently through the system. The longer that food material takes to move through the system, the more likely you are to get gas buildup, pain, and distension. All right, as you move out of the small intestines, you then start collecting into the large intestine, which is the colon and the rectum. And it starts on the, let's see here, looking at the screen, it's the bottom left, but on us, on our person, it's the bottom right, is where the colon starts collecting. And that little horn coming off, that is your appendix. don't worry about it, but that's what that is in the picture in case you were wondering. So the bottom right is where the colon starts collecting, and then it ascends. So it's the ascending colon up to the transverse colon, to the descending colon, and to the rectum. And so it's these different segments. And the purpose of the colon is largely to consolidate stool and take the water back out of it. So it's kind of your camel. It wants to hold onto the water so you don't have to hydrate nearly as much as you would have to hydrate without it. So if somebody is abusing laxatives and fluid is moving too quickly through the system, a lot of water gets lost that way. And then if there's constipation and stool is moving too fast or too slowly through the system, then you're getting harder and harder, more constipated and dried stool that is hard to move. Like we said earlier, if somebody's been abusing laxatives, we withdraw them, but then we try to help keep that water in the stool by using the osmotic laxatives until the system starts picking up and moving things along better. Anytime water is moving quickly out of the system, we're going to get some electrolyte imbalance potential as well, which goes toward the cardiovascular system and the muscle system functioning like it's supposed to, and the neurologic. All right, if a patient is abusing enemas, that can introduce water that doesn't have electrolytes into the colon. And since the colon's job is to pull water out, it can be especially dangerous to use enemas as part of somebody's laxative abuse process, because not only are they losing electrolytes rapidly through moving stool materials too quickly through the colon, they're also introducing free water. So the body that's looking for water is going to absorb that back in, and the electrolyte levels can fall more rapidly. So that is a more dangerous behavior and definitely needs to be corrected as quickly as possible. And the patient needs to be educated, because a lot of people do not think of that as being specifically harmful. And they're always really surprised when we talk about it. Okay. In interest of time, I'm going to recognize that everybody can read, and I'm not going to go with that last little paragraph right there, but we're going to move on to orthopedic. And for that, I want to just talk a little bit about normal bone health, and that'll help the abnormal bone health make more sense. When we are growing and developing, our bones are growing both in length, which provides us more height, and then also in density. And the density is kind of like if you're building a bridge structure, as you put in more and more and more supports, you're building the density. So density helps our bones be strong and stable. And our bodies are so smart that as we're doing physical activity, our body says, oh, I'm getting strained this way and I'm getting strained that way. And it puts those bridge supports in the position that best supports that kind of a strain. So in a well-nourished body with good estrogen, good calcium intake, and good vitamin D is important because it helps your body absorb the calcium. Without the vitamin D there, all the calcium you're taking is not getting absorbed very well. So those two very much have to go together. In that context of a very well-nourished system, then strength training, things like yoga or doing light repetitive weights, are really good at building bone health. And so people who have been active and athletic throughout their growth years and well-nourished can tend to have very good bone health. Our genes also play a strong role in our bone health. When we are not getting the nutrition that we need, or we're overdoing our athleticism, as bones develop, I mentioned earlier, the body's really smart, and it says we're getting stressed in this way. This is where we'll build the bone and make it stronger. But the way that it does that is as you go through your muscular and active behavior every day, you break down a little bit of muscle tissue and a little bit of bone tissue. And then as you rest and in the context of nutrition, your body comes in and heals those areas and make it stronger. So if you are being active in a normal fashion or above a normal fashion in a compulsive or excessive fashion, you're breaking down bone and muscle tissue. But then when you're at rest and your body goes to heal that muscle or bone tissue, it doesn't have its building blocks. So whereas somebody is doing that activity and you would think, oh, they must be really strong and they've always done that activity, their bone health could be really strong. If it's occurring in a malnourished state, you may actually be depleting bone health faster than you can build it. Up until age 24 is our best time in life to build bone density. We do know that in somebody who has had some bone density loss or lack of development in their younger years in the context of malnutrition, that if they get nourished, stay nourished, and don't exceed their body's day-to-day demands, but do activity in a way that is supported by their nutrition, their bone health can improve over time. So we've definitely seen some women who've had abnormal bone scans go on to have improved and sometimes even normalized bone scans with sustained recovery, or interval sustained recovery. The endocrine system is responsible for many different functions, and we've talked about them some: osteopenia and osteoporosis. That's the low bone density that we just talked about. Every system in here, of course, requires nutrients to help build whatever the chemicals are that are the communicators within those systems. And each person's body may respond differently to a malnourished state regarding how resistant or how fragile it is to these various things. So with growth hormone, if you are in your growth years, but you're not getting in the nutrition that you need, some people's bodies will prioritize growth and they will continue right along their growth charts as they were going to be doing it. And then, and there's an example of a growth chart right here. I think all parents are very familiar with them. And you can see girls and boys are there separately, but that they grow very similarly up until that age when girls around age 14 or so stop growing in height as much. And then the boys just take off after that. That's what this growth chart is. I'll say as an aside that if you have growth charts for your loved one or for yourself, they can be a good indicator of where the body was naturally headed in growth before the onset of an eating disorder. And then also kind of looking at it over time, how has the growth chart changed while somebody's had changes in their activity level, their nutritional area, things that have happened in their stages of life. Sometimes looking along that growth chart can be really helpful in learning more about how the body's been impacted. But if somebody's in their growth years and their malnutrition kicks in, as I said, they may be resilient and continue to have the normal growth, but then other people will fall off of their growth curve. And whereas it was headed like this before, it'll start to flatten out a little earlier. If somebody has that occurring and they can get some nutrition on board on a regular basis and get back into a stage where the body can prioritize growth before they would have stopped growing anyway, you might recapture some of that growth curve. But if nutritional recovery doesn't happen until the body is already at a stage where it would have stopped having growth in height, you can't recover that growth in height. So that's something to think about. That's really important in those years between ages 10 and 14, where eating disorders might be starting, but the person may still be within their growth years, is that if they're falling off of their growth chart, that might be an indicator that they only have a really short period of time to potentially get some of that growth in height back that they would have had without the eating disorder. Thyroid, some people can have thyroid disease that has nothing to do with their eating disorder, but what we see most often is somebody who's never had thyroid disease, but within the context of their eating disorder start to have unusual thyroid labs. That's an indicator that the body is struggling. And sometimes people will be put on Synthroid or thyroid replacement that is not actually needed, because once the body is nourished, the body will take on that thyroid function just as it can whenever it's well nourished, and then you don't need that thyroid hormone on top of it. So malnutrition may cause the appearance or even a diagnosis of a thyroid disease in a body that it does not exist when it is nourished. Delayed puberty. If your body was starting puberty and the eating disorder started and malnutrition started, it may have slowed down or stopped and continued to be stopped for a long period of time. We've seen in our adult program women who have not ever completed pubertal maturation. And obviously then in the adolescent program, they see people who are in a suspended state as well. By getting the nutrition back on board, we usually see the body start that development back up, and then either kind of go along at the rate that it maybe would have gone otherwise. It's just delayed by however long the disease state had been going on, or it may go gangbusters and have a lot of development really quickly. And those are things that we want to be aware of with our patients, because that's a time of body change that is difficult for all people, male and female, with or without eating disorders. It's just a difficult time to have the body changing so rapidly. And so if our patients are experiencing that, we want to be present with them in that and be processing it with them. I'm going to keep talking. There's also then amenorrhea. Amenorrhea is loss of a menstrual cycle. And it could be a loss or a change. There's primary amenorrhea, which is when somebody never got their menstrual cycle to start with. And then there's secondary, which is when they lost their menstrual cycle in the course of the malnutrition. In either of those circumstances, we expect that with nutrition, that menstrual cycle is going to return, and normal fertility will return if the patient is in full recovery. If somebody is still struggling in their recovery, they may still have altered fertility patterns until they're really in full recovery. Orthopedic, we talked about that earlier when we were talking about the bone density, and then this is just kind of a slide to remind us that bone density really speaks to fracture risk. As somebody's having reduced bone density, they're having increased risk of fracture if they were to have a fall, or in the worst cases of osteoporosis, even without a fall. I feel like, okay, so that was just a redundant slide. And then hematology, immunology, that is the production of blood cells throughout your bone marrow. And it's a really high energy system in that it requires a lot of resources to make those blood cells and make them as healthy as possible, and then to keep them going, because every blood cell has a life of so many days or weeks. So it's a constantly turning over system. So people with malnutrition that just don't have good resources will have a slowing of the system and may have anemia or low white blood cell counts. And then as nutrition is kicking back in, we'll see that the body starts to restore those. We need to make sure there's good iron stores by checking the lab, and if it's low, supplementing it, but we don't need to supplement it if it's in a good place. We just need to monitor. And then platelets may actually rebound into the higher than normal range in early recovery. And that can be an alarming lab to see, but it's actually part of early recovery that we now recognize is usually very benign. And if we just continue to follow it, we'll see those labs normalize over time. All right, and then vitamin supplementation. Briefly, I'll just say a multivitamin is fine. There's data that says that some people don't really absorb multivitamins and make use of them very well, and then other people do. If somebody is well nourished, otherwise, I don't think that they do need a multivitamin. But in the case of malnutrition, supporting with a multivitamin is kind of a no harm, no foul option. But you don't need a fancy multivitamin. You certainly don't need one that says that it contains energy. But just a standard multivitamin, and then if indicated, supplement with these other vitamins. And so we'll check labs on that. And if the labs are abnormal, then supplement. All right, I think this is our last slide. And then benefits of exercise restriction, or our last topic. We pull back on activity altogether at admission, kind of regardless of which eating disorder somebody might be suffering with, because it's all part of that energy balance pattern. For some people, pulling back on exercise restriction will facilitate weight restoration. For another person, it might just break that pattern of I can eat, but only if I'm having activity. And so instead, we're reinforcing the idea that your body deserves to eat and it needs to eat regardless of what behavior is occurring with activity. Also, that until the nutrition is more in place, as we discussed earlier, exercise is muscle and bone destroying rather than building. And then finally, it allows us to reintroduce exercise and for somebody in a way that is judicious and with guidance and processing as somebody improves that activity in their early recovery. The reasons to reintroduce it includes strength and physical therapy. It really is like a physical therapy for bone healing and for muscular healing in a body that has experienced those losses. Stress reduction, emotional centering, just as it is for anyone, but then also relearning body connection and awareness. A lot of our patients get to a point either in their illness or during early recovery where they are not connected to their body because their body represents things that they haven't been able to accept or be comfortable with. So having movement in a way that is thoughtful, like in yoga, can really help with this as a therapeutic tool. All right, we'll be receiving some questions, I think, through you writing out and sending in so that we can sit down together again soon and look over those things together. And I look forward to hearing from you. Thank you.